So I'd like to call the meeting to order, and if you'll rise with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, Dean, if you could call the roll.
Director Nicholson,
Present.
Director Yee,
Present.
Director Stewart,
Present.
Director Epen, Director Wallace.
Present.
Great, thank you. So welcome to the December 8th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows a local agency to continue to hold its meetings remotely, as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to Alameda County Health Care Services Public Health Department COVID-19 website at www.covid19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing.
Mr. President, so moved.
Thank you. Do we have a second?
I'll second.
A second from Director Yee. Thank you. Dee, could we have a roll call vote?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen, Director Wallace.
Aye.
Thank you. The motion is affirmed. The motion passes. The finding is affirmed. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. We'll now move to the communications segment of the agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, are there any written communications, Dee?
No, there are not.
Okay, we'll now move on to the election of officers. Every year in December, we elect a new slate of officers, and it would be my pleasure to entertain a motion.
Mr. President, I would like to nominate the following slate of officers for the year 2021 to 2022. As President, Jeannie Yee. As First Vice President, Bernard Stewart. As Second Vice President, Michael Wallace. As Treasurer, Jacob Epen. As Secretary, William Nicholson.
Thank you, Director Stewart. Do we have a second?
Second.
Very good. Dee, if we could have a roll call vote?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen, Director Wallace.
Aye.
Wonderful. The motion passes, and Madam President, the gavel is yours.
Thank you very much. I do want to thank the directors, Director Wallace and Epen and Stewart and Nicholson, for their collaborative leadership and unique experiences that combine to make the board one of diversified strength. All of us want what's best for the health and well-being of the residents of our district, and it's a real privilege to be able to serve with you. And special thank you to Dr. Nicholson for your leadership this past year. You continue to teach me and train me and help me, and I've got big shoes to fill, but I know that you'll be there to help me grow in this new role, and I thank you. All right, let's move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Okay, does any member of the public want to remove an agenda item from the consent calendar? All right, hearing none, may I have a motion to approve the consent calendar items A through F?
Madam President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through F.
Thank
Second.
you, Dr. Thank you, Mr. Wallace. Thank you. All right, Dee, can we have a roll call vote, please?
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen, Director Nicholson.
Aye.
All right, so that motion passes. Thank you very much. We are going to move on to our presentations and reports, but we're going to take a report out of order, and it will be our quality report from Dr. Aquilili, the 2021 Critical Care Program Update. Kimberly, would you like to do the introductions, please?
Yes, thank you. It is my pleasure to introduce Dr. Carmen Aquilili. I know she is known to many of us, but Dr. Aquilili has been practicing medicine in Fremont since the early 1990s. In 2008, she became the director of the intensivist program for critical care. Dr. Aquilili is board certified in internal medicine and critical care. She is also a fellow of the American College of Chest Physicians and a member of the Society of Critical Care. She is currently the medical director of the critical care and intermediate care units and is the interim medical director of our palliative care program at Washington, which began in 2016. So thank you, Dr. Aquilili, for joining us this evening.
Okay, thank you very much. Good evening, everybody. Avi is supposed to set up my slides.
Go ahead, Dr. Aquilili, when you're ready. You can see it?
No,
All right.
where's
Oh, you
the
can't?
So I can't see the slide, but
Hold on.
We lost. We lost you, doctor.
oh,
We don't,
Lost the visual.
We don't see you.
you don't see me?
No.
It says Zoom is not responding, so
Oh,
maybe I should
no.
just.
Why don't you log out and log back in very quickly here? I think that will be helpful
Okay,
because we saw you before.
Actually, just checking in, this is Bernie. I had a visual of the slides.
Yeah, I think we all did, but I think Carmen's machine probably froze. We can see the slides, but not Carmen.
Coming back on.
Right, because she was off the screen, but we could still hear her.
Yeah, we could still hear
I
her.
think she was using her phone.
Yeah, Dr. Aquilini, if you want to just, if you have a paper slides, you could always just do it that way, and I think she logged out.
She logged off.
Yeah, now she logged out.
She had trouble with Zoom the other day. She
Hmm. There
I'm
she
here
is.
now.
Okay.
So my slide, I don't see the slides. Okay. All right. Good evening, everybody.
Yay.
2021 critical care report. Next slide, please. Just want to let you know historically, next slide, that we were established in 2008, like what Kimberly said. We were 24/7 intensivist consultation only in 2009. And then in 2016, we started with the board approval, the intensivist-led critical care, which means we are the sole attending of all patients that come to ICU, and we're responsible for their safety and care. And then in 2018, again, thanks to administration and the board also, we went to Maurice Hyman Critical Care Pavilion with that expanded 48-bed ICU, 32 beds for critical care, and 16 beds for IMC. Next slide, please. So our program calls continue to be to provide the highest quality evidence-based patient-centered care, and the vision is to engage the patients and families in a comprehensive, highly coordinated with a human touch, not only high-tech. So we continue to identify and improve the condition of critically ill patients, provide appropriate, reliable, and timely care, again, integrate and engage patient and family to care, and create an effective interprofessional care team led by the intensivists. And this has been going on. Next slide, please. So aside from the care team, the intensivist-led model, we're usually 2 intensivists per 12-hour shift. We're 22 all in all, 8 full-time and 14 part-time, 100% critical care board certified. We are from different specialties, mostly internal medicine, 10 from pulmonary, 4 emergency room doctors, 5 internal medicine, 1 anesthesiologist, 1 nephrologist, and 1 surgery critical care. So it has been 24/7 coverage since July of 2009. Next slide, please. To sustain and maintain the efficiency of our unit, we created in 2014 the Clinical Ops Committee, which is the backbone of our group. So we do monthly group meetings, and this is interdisciplinary and co-chaired by the ICU nurse manager and myself. And of course, the objective is to review critical care patients' outcomes and quality, and discussion of evidence-based practices, policies, and procedures. Next slide, please. So for the volume of admission, as you know from last year's report, there's decreasing trend in the volume of admissions over the past 8 years, but there's increase in the acuity of patients and intensivist-led appropriate admissions. So we do this by having the Apache score, which is acute physiologic and chronic health evaluation. We do that in the first 24 hours of the patient admission. And Apache is a general measure of the disease severity based on their physiologic measure. So to give you an understanding, an Apache score of 25 means a mortality risk of 50%. And if the Apache score is 35, 80% mortality risk. So for Washington Hospital ICU in 2018, our average score was 18. And for 2020 to 21, the average score is 22. So that gives you a mortality risk of between 30 to 40%. So our patients are sicker, but they're appropriately in critical care. Next slide, please. So the top 30% of primary diagnosis of discharges did not really significantly change since 2020. It's mostly included COVID, sepsis, and cardiac diagnosis. Except now in 2021, our number one is COVID pneumonia. And the respiratory failure is probably included to this because most of the COVID pneumonia patients are in respiratory failure. So sepsis has been our number one for the longest time, now second to COVID. And cardiac diagnosis, non-STEMI, is the third. Next slide, please. So if you look at our COVID admissions in ICU, it's hospital-wide, it's also male predominant, 70% of them, and 65 and above. 1 out of 3 are obese based on the BMI on admission. And most of them, 1 out of 3 are Hispanic patients. And second are the non-Hispanic white and black. And the third are Asians. If you look at the bar graph, you'll see that there are 3 waves. In July and August of 2020, we have the first kind of wave of admissions in ICU. The second one, the highest, was in December 2020 to January 2021. And the third wave is this year, again, July to August. Next slide, please. So these are our outcomes. There is decrease in COVID cases admitted to ICU from 2020 to 2021. So from 35% in the first row to 23% in 2021. And it tallies with the benchmark of 17 to 27% from CDC. For COVID mortality, there's not significant change, 37% in 2020 and 39% in 2021. The use of mechanical ventilation also is a little bit less in 2021, 38% on the third row. And then the message here is that most of the mortality are from the unvaccinated patients with comorbidities. As you see on the last, on the second to the last row, we only have 10 vaccinated patients admitted for severe COVID casing, meaning to say those that needs oxygen. Out of the 10 patients, 10 vaccinated patients, 2 were admitted to ICU. These are renal transplant and stage renal patients, and the 2 of them passed away. So very few vaccinated patients were admitted in the hospital or even in the ICU. Most of these mortalities are from unvaccinated patients with a lot of comorbidities. And then at the very last row, you'll see the ICU average length of stay was almost the same, 11.6 and 11.3. So you know there and then that it will increase our length of stay. For the next slide, please. So that's my COVID data. Let's go to our evidence-based practice. We got most of our evidence-based from Society of Critical Care recommendation. Our focus was the COVID management, and then secondly, infection prevention, which is also from the NHSN. And then the A to F bundle ICU liberation is continued. ICU readmission is also being seen because they can increase length of stay and increase mortality. Pain control is very important to us, severe sepsis and septic shock, and palliative care and end of life. Next slide, please. So when it comes to the A to F bundle and delirium, we have shown that we have decreased the prevalence not only because of changing in medication, but also I think the environment. When we went to Morris Simon Critical Care Pavilion, our prevalence has decreased and continued to be maintained at around 9%. The environment has helped because we have single private rooms, glass doors and windows and sunshine, and making the day and night, confusion by the patient much better. So that was good. Next please. Next slide, please. So for the length of stay, there's, if you look at the red line is the 2021 length of stay. It's higher than last year. Our benchmark, internal benchmark, is about 4.49, and the bar graphs are all COVID length of stay cases. So there's decrease in length of stay over the course of the year, meeting the benchmark in October of 2021. It's going down, but the trend is moderately correlates with the trend in COVID length of stay during the first quarter. If you look at it, the second half was slightly on the lower one, but that was because of the better throughput and cardiac surgery patients going to telemetry. So next slide, please. It also helped that our patient flow has significantly improved. Our goal is really from the time we order the transfer to the time the patient is transferred physically is 6 hours. But it's not happening, but the trend at least is going down if you take a look at the blue line. So this is because also improvement in our throughput committee and hospital-wide triaging. So we're hoping that the 6.5, it will go down to 6, and finally we'll reach our goal for our patient flow. Next slide, please. So mortality, again, as I warned earlier, is slightly higher than the last couple of years. But the range that we have was the SCCM 10 to 29. So we're still within the range, but we're running higher than what we were last year. And again, COVID patients accounted for the high mortality rate in the early 2021. And next slide, please. And if you can see in the bar graph, the orange colored one is the ICU mortality due to COVID, and the blue one is unrelated to COVID. In the first couple of months, we have more COVID mortality, and in the last couple of months, it's a little bit less. The blue one in July, if you look at the mostly blue one, this was not due to COVID. When we drill down on the case-by-case basis, we found out this is mostly due to 6 cardiac arrest patients and 3 brain hemorrhage. So that's kind of different mortality. Next slide, please. We also look at readmissions because, as I mentioned earlier, there is associated usually with significantly higher morbidity and mortality. It increases the ICU and hospital length of stay and increases the cost. Also, it's nice to also look at whether it is a premature transfer for an inappropriate level of care, failure to respond to therapy, whether it's preventable or not preventable. So if you look at the second slide, the readmission within 48 hours was better than the benchmark, which is around 4%. But the readmission for within 24 hours has more variability. So there's no national benchmark for readmission, and the articles that we found with SCCM are mostly looking at 48 to 72 hours. They have not looked at 24 hours, which probably is a little bit unrealistic, but because we're doing it here at Washington, we're as strict as that, 24 hours, and our internal goal is about 1%. We are a little bit higher than our internal goal. And mind you, these are patients, if you look at January, that's 1 patient, February, 1 patient, but still we follow that up. The July 1, 2.5% is about 2 patients out of the discharges. So based on this, we drill it down, and only 2 out of the 7 readmission in 2021 were potentially preventable. Most of them are not preventable, meaning to say it's a development of a new clinical disease process or worsening of the disease process. Those are the non-preventable ones. So our action plan is to continue preventable and non-preventable readmission identification. We also want to continue clinical case review to understand the reasons behind the readmission and improvement in the provider communication when we're doing handoff. An example of this is our patient was slightly delirious and it was not communicated well. So when the delirium got worse in the floor, the patient needed to be back to ICU. So if we could have done a better job in communication, then it could have been, we could have avoided a patient from being readmitted. Next slide, please. So ventilator outcomes are one of the quality measures we have, and we've been following up. And of course, the only place where you have ventilators are in the ICU. So our outcomes have been better than the benchmark over the past 10 months. And the higher duration on ventilator this year was due again to the surge of COVID. Our reintubation rate on the left side, you'll see, is also within our benchmark. And the unplanned extubation are also within benchmark. Our benchmark from the ventilator days are from SCCM, and the reintubation and unplanned extubation of our AARC, the American Association of Respiratory Care. Next slide, please. So when we talk about ventilator-associated events, this is part of the highlight of what we're following up closely. A hospital-acquired infection, which is the priority focus for last year and especially this year. The National Healthcare Safety Network is CDC's healthcare-associated infection surveillance system. So they use a standard method to collect the data. It's mostly the device-associated hospital-acquired infection. For the ventilator-associated event in 2013, they changed the ventilator-associated pneumonia to make it an event, meaning to say, aside from pneumonia, they also want to look into pulmonary edema, other causes of why the patient is staying on a ventilator, like ARDS or just lung collapse and things like that. Because it's important, because being on a ventilator increase what? Length of stay, increase the mortality of the patient. So this is not yet reported. It's not currently reported publicly, but it's a quality measure for this hospital, and we follow it up closely. So if you look at the bar graph, it was really very high, 3.674 of SIR in 2020. And then we have an action plan as noted here and showed some decrease in the SIR, but our goal is really less than 1. So the action plan, we had alarm for the ventilator setting in EPIC. The current practice, we expanded our bundle to include VAE bundle, which not only look at the mechanical ventilation maneuvers, but conservative fluid management, identifying modifiable risk factors, those kinds of things. And we also have a staff reminder for patient-specific ventilator settings in front of the door. This is a vented patients, these are the settings, so that it reminds not only the RT, but the doctors and the nurses. And the upcoming one is a quality and ICU task force that's being created by Mary Boron from Quality for VAE prevention. Next slide, please. So if you look at that, I'm not blaming COVID, but again, if you look at the orange colored bar, and they're all from COVID vented patients. So if you take away the orange colored bar, our VAE event would not be too high. So again, majority of them was due to COVID. Next slide, please. So part of the hospital-acquired infection are also the CLABSI and the C. diff. We didn't have much problem with them. There's significant drop in 2021. As you can see, in C. diff is the black one and CLABSI is the blue one. The kind of light blue gray one is CAUTI, the catheter associated urinary tract infection. So that is the other problem that we have, the VAE and the catheter. So the action plan we did when we saw that was strict surveillance for the Foley catheter use increased use of straight catheters instead of that indwelling catheter forever. We use bladder scan, external, the female external catheter, the PERWIC we call. And then we even use some medication for those patients that have bladder obstruction from benign prostatic hypertrophy to just take out that Foley catheter, because that's the source of the infection and the source of length of stay and the source of more morbidity for patients. And then, of course, we have daily post-CAUTI case review and discussion. As you can see, in July and October, it's going down. It's about the standard infection ratio is 1.41. So it's on its way down. If you that is the latest one that I got. So hopefully it will stay lower. Next slide, please. So patient's experience. We have always been, the blue one is overall experience, and ICU rating is the dark blue one. So we'd like to be 100% all the time. That's our goal. The newer one too that me and the CEO is looking into is the individual physicians, individual intensivists. So we're not there yet, but we're working on who is making our patient experience better or who is not making it better. So next slide, please. So part of being in intensivist is also educating everybody or learning also from other people. So we are finally had that lecture on the benzodiazepine sparing alcohol withdrawal lecture. What it is trying to use medication that's not Ativan that can cause respiratory depression and eventually get the patient intubated while you're trying to give them medication to calm them down from their alcohol withdrawal. So now with the benzo sparing alcohol withdrawal lecture, we're able to kind of start the order set and the protocol. So since we've done this, the initial studies showed only one patient that alcohol withdrawal patient that got intubated. We have decreased the amount of patients being more sedated and being intubated. So we hope that this will continue on. We will try to also give that data next year. So we continue to contribute to the community by giving that yearly lecture with an with emergency room. And then this year also the ICU nurses with the intensivists educated the telemetry nurses on the post-CABG patient and cardiac surgery patients so that the cardiac surgery patients will feel, doctors will feel more comfortable transferring their patients to out of ICU and not staying there forever. Next slide, please. So what we want to do is to continue our family-centered care initiative with focus on communication within each other. We still need to, as of now, despite all the tools that we have, we still need to have our communication, whether it's a huddle, whether it's rounding multidisciplinary, and also improve our communication with patients and families. We want to continue to support the post-op management of cardiac surgery patient and TAVR program, which is increasing in our ICU. And of course, we want to work in decreasing hospital-acquired infection. In critical care, our focus is to attend this VAE quality task force that has been started by Quality. Next slide. And that's my report. Thank you very much. Any questions?
Thank you, Dr. Aquilli. We appreciate you and your team and their continual stress on high goals and standard of care. It's been challenging. And I know you all have been learning a lot and communicating well with families and patients and taking good care of our residents. So thank you. And any questions from the board? Any comments?
Just great
Very good.
work, Carmen.
Yeah.
We'll continue. Thank you, guys.
Thank you
Board of
all.
Director for helping.
Thank you for logging in tonight and sticking with it and giving us your report. All right, thank you. We'll let you go. All right, so moving on, we'll move on to our presentations. Next, Dr. Stewart and Mary Bowen have a presentation for us on COVID-19, the Omicron variant update. Kimberly, can you introduce that for us, please?
Yes, I will introduce Dr. Jeffrey Stewart. He's our Chief Medical Officer at Washington Hospital, and he's been a member of our medical staff since 1994. Prior to this role, Dr. Stewart, an anesthesiologist, was the medical director of Washington Outpatient Surgery Center for 14 years. He also serves as a surveyor for AAAHC, the Accreditation Association for Ambulatory Healthcare. And then also, I just want to introduce Mary Boron. She's our Chief of Quality and Resource Management, and she's been at Washington Hospital Healthcare System for 12 years. She received her Bachelor of Science in Nursing from the University of San Francisco and worked in Med-Surg and Emergency Department Nursing for 7 years before transitioning into infection prevention in 2009. She obtained her Master's of Science in Nursing from the University of San Francisco. She's a certified clinical nurse leader and is certified in infection prevention. So we thought today it would be good to provide the board and the community with an update on Omicron, and I think you'll see that there's a lot of information that is still being developed at this point, and that there are many unanswered questions, but I will turn it over to Dr. Stewart and Mary Boron.
Great, thank you, Kimberly. And yes, anybody who looks at the news or searches the internet now, you can see hundreds of articles in varying from complete hysteria to no big deal with respect to Omicron. So obviously this is all really in flux, and we're really just getting some information on it now to even make any judgments. But what Mary and I, just in a few slides here, would like to do, just kind of summarize what's kind of accepted and what we know, and kind of maybe level set for everybody going forward. And that's what we're going to try to do here in a brief presentation. So if I could have the next slide, that would be great. So again, just to start, the Omicron variant, as everybody knows, we heard about it first from South Africa. And I think at this point, most of us are aware that a virus mutates, and that's part of its natural life cycle. So the fact that a virus is mutating is not shocking, but rather expected. When a virus mutates, it can change the characteristics of the virus, as we've also learned about. And when we're talking about a variant is a change in the genetic code within a virus that contains various mutations. Can be one mutation, can be in the Omicron variant, multiple mutations. And depending on, we've heard about a lot of variants in the news, but we've not at all heard about all the variants that have been out there, because the ones we've heard about are really the ones that get to the level of being designated by the World Health Organization in particular, but all health organizations, as variants of concern, or there are some other labels as well. But the ones we're focused on are the variants of concern, because as is laid out here, a variant is described as a variant of concern if it meets certain characteristics, at least one of these. Evidence of an increased transmissibility. In other words, it's easier to catch the virus or have it go from one person to another. More severe disease, which again, at this point, it's very hard to say with respect to the Omicron, or a significant reduction in the neutralization of antibodies generated by previous infection. And I would just comment on that last one real briefly, just to not to get too off track, but you're going to read a lot of stuff in the news about how various antibodies and antibody treatments, either you show evidence they work or don't work with respect to variants. And initially, and we're at that stage now, we really don't have as much real world information on that because we haven't really had time. A lot of this is lab based. So that's something to be really aware of, because again, there's so much going on. You can read something quickly and just kind of accept it as truth, when it's really, everything is much more nuanced than that. And with respect to this variant, in the end of November, a couple of weeks ago, the World Health Organization did classify Omicron as a variant of concern. And one thing that I will throw in here, because I'll do it a couple times, given a by association with the vaccines and how proud we are at the hospital of our vaccine rollout, is that throughout the entire pandemic thus far, clearly the vaccines have held up with respect to severe disease against all the variants that have been out there. There's no reason to think, despite what we're reading now, that this won't be the case with respect to severe disease with the Omicron. But again, it is very early, but I'm just basing that on logic and some of the people I trust on the topic. We can go to the next slide, please. And here's just the general timeline of what happened. Really, it seems like it's been longer, but it's really only been a little over 2 to 3 weeks since the Omicron variant was announced as being detected in South Africa. Again, just as this is a key point with respect to the spread in South Africa, which has been impressive here in the first 3 weeks of being detected, is that South Africa really is a very low vaccinated population. With respect to, I think when this started, maybe about 25% of their population being vaccinated, which, you know, contrast that with our population where it's closer to 70%, it's very different. A travel ban was instituted by the government on November 26th. And then, you know, the next day, a bunch of cases were recorded outside of South Africa. The first case was recorded here in California on December 1st. And the reality is that a lot of people think, and it's, I think, fairly accepted, that the Omicron variant probably has been here or was here before the first case was detected. That wasn't as if it just arrived here on December 1st. And I think we're just, you know, being able to detect it now. And then this is associated with the fact that, again, while it's early, it does seem like early evidence seems to indicate that it is a milder infection. And again, in a heavily vaccinated population, that also makes sense, and that's probably part of it. But there's probably a lot of people who are either asymptomatic or mildly symptomatic who may have had the Omicron variant who never got tested in the first place. At this point, it's been detected, I think, in even more than 38 countries. The slide, you know, because things are changing even as the slides are made. And in California, I think we're well into the double digits in cases now. So even though it says both cases, I will say from what I looked at even this afternoon, I've not seen any reports of California of severe disease with any of the first cases of Omicron. And again, it does seem to be that, at least so far, again, things seem to indicate that it does appear to be milder. But while that is encouraging, and I am an optimist on this stuff with respect to the vaccines and how they help, I do caution that it is early. And additionally, on the I think the little more the side of caution, there is a lot out there saying that it is more transmissible, which, you know, is logical as well, given the mutations around the part of the virus which attaches into the nasal mucosa where the virus kind of sets up home base when it first enters the body. But again, it's very early to tell. And before I turn it over to Mary, just one thing I would share is I saw an interesting interview with my go-to person on this topic, which those of you who've talked to me about it know who that is, which is Dr. Monica Gandhi from UCSF, who actually gave a grand rounds at the hospital. It was a really interesting interview talking about how maybe even counterintuitively, if it might be good if this is a milder version of COVID, which is more easily transmitted, given that would build up more immunity throughout the population. And there are some theories going back to the Spanish flu that, because there was no obviously sequencing or testing really going on then, that something like that happened over the course after, you know, the 15 million people in the world passed away, where it kind of burned out and nobody really figured it out. And so again, we're 3 to 4 weeks into this. I think, you know, staying calm is the right approach, and kind of being trust but verify with the information that heads your way. And with that, I will turn it over to Mary for the next slide.
Thank you, Dr. Stewart. Yeah, some additional good news about this is that the current methods that we use throughout the country and the world to test for COVID so just being PCR and antigen tests can detect this variant. So that's good news. It does take an additional step of genetic sequencing to identify it as this variant, and the technology is there to do that and the process. The CDC has identified some guidelines for us on who to test, and they're currently recommending that anybody with recent travel from the Southern Africa area is what really the population we should be concentrating on for risk. And as Dr. Stewart said, it started in South Africa and then has just disseminated through it at a fairly rapid pace for the short period of time. So the entire region of Southern Africa is the considered risk travel area. Now, as the domestic community transmission increases, this will become less of a factor that we can consider. But right now, travel is the risk factor area. And when people travel and arrive back to the United States, the CDC is recommending that they quarantine for 7 days, but within the first 3 to 5 days, they get tested. This would help us identify cases sooner, and if they are quarantined, obviously would decrease the risk of spread. In addition to that, just like with any form of COVID, isolating and testing if you develop any respiratory symptoms. So those are just general community guidelines for testing. Moving on to the next slide, I just wanted to focus a little bit about what we're doing here at Washington Hospital for making sure that all of our controls and measures and recommendations are in place. The continued good news is that a lot of what we've been doing will continue to work in controlling the spread of this variant. There is, of course, the extra strict focus on screening all of our patients with travel history. We are screened for travel history year round through all of our admissions, elective and the admissions that come in the ED. This specific area of the southern area of Africa is included on that list, and patients are all asked that in their screening. We continue to screen and require visitors to show their vaccine status, which is in the form of showing your digital vaccine or your hard copy of your card. And we do respiratory symptom screening. And that is for everybody who enters the hospital. The healthcare workers, obviously, we know their status and we have a separate process, but we're also following very strict guidelines with our visitors. We also, in addition to this, are collaborating with the California Emergent Infection Program. And this is a program that is actually a public agency, and they work directly with hospitals to make sure that we are testing patients appropriately. And if we identify a patient who meets the risk criteria related to their travel, we actually have the ability to send that test directly to them so that we can make sure that it has the extra testing steps that it requires. We're set up to do that at the hospital. And we haven't had to send out a test yet, but if we have somebody who meets this risk criteria, we will be prepared to do so. One of the additional steps that really has worked well in preventing the spread of COVID is the universal masking in healthcare settings. And we'll continue to do that for what we're guessing will be an extended period of time, especially going into this season of the winter where respiratory illness spreads. This is going to continue to be really important. This applies to everybody who enters the healthcare system, whether you're an employee, a visitor, vendor, patients also, when they have the ability to mask, are asked to mask. And this has really helped decrease risk and kept our patients and employees safe. We continue to run our COVID vaccine clinic, making the booster available and vaccine available to all of our healthcare workers, patients, and members of the community. That is going to be one of the key factors moving on with any variant, and it appears to be a help with this particular variant so far. Again, that information is all new and changing quickly, but vaccine is absolutely one of the pillars to preventing this getting worse. One of the things that our employee health services here are very strict about is making sure that management and employees are aware of when employees need to stay home, and any healthcare worker. And if any of them are sick or showing any early signs or symptoms, we always err on the side of caution, and that healthcare worker is asked to stay home and to test if symptoms persist. We do internal testing for them so we can get a rapid result. That way we can keep up our healthcare staff that would no longer be at risk if they test negative. So that's guidelines that we are really strict about and have had some good success in making sure that we do not spread COVID amongst the healthcare workers to the patients. Also, social distancing remains very important. I think even the method that we do this board report in, still continuing to do it in Zoom as an example. Most of our administrative meetings continue to be in Zoom. And when we do have to be in a room together, we follow social distancing. We do that with all of our meetings and interactions at the hospital. This variant is just another reminder on why we need to continue to do that, and we're keeping that a high priority. And as with any infection, the absolute single best method on preventing the spread is breaking the chain of infection through the form of hand hygiene. Washing our hands is something that we did focused way before the pandemic, and continue to focus on and will in the future. So we'll always be ensuring that we have good hand hygiene practices, monitoring, educating. That is just an ongoing effort that we do throughout the whole system. In addition to that, our employee health department has actually requested that our healthcare workers tell us on a volunteer basis if they've had recent travel, so that we can follow the CDC guidelines on how to address that. And we've asked to defer travel to high-risk areas when feasible. This is not just a recommendation in the healthcare system. This is a recommendation that obviously CDC is following, and the state. And I think with those interventions, we'll continue to monitor. And as Dr. Stewart said, this is a rapidly evolving situation, but this is sort of our map for how we're going to respond to this particular variant.
Wonderful. Thank you. Thank you, Dr. Stewart and Mary, for the update, for reassuring information. We thank you for staying on top of it. So our patients, our staff, everybody can be as safe as possible. Does anybody have any questions for either of them?
Yeah, I have a question either for Mary or Jeff. Is how soon do you think we're going to get reliable data as to, number one, the efficacy of the monoclonal antibody treatments against Omicron, and then number two, how effective the mRNA vaccines and the J&J vaccines are going to be against this variant? What timeline do you think we'll be getting that data from what you have been able to research?
Mary, do you mind if I go?
Please, thank you, Dr. Stewart.
Okay. No, from what I've read again from people I trust, a few of them, I mean, the data is starting to come in. I mean, I think even I don't think he spoke to specific studies, but even just I think Dr. Fauci's tone over the weekend when I heard him talk about the milder severity of the disease, he seemed to talk with more confidence. I have seen some preliminary studies on some of the, I think of the Glaxo antibody treatment being still being effective. So just, the logic to me tells me over the next 2 to 4 weeks, I think we're going to have much better information, certainly within the month. I think that will, be interesting to see what we find out. But I think the next 2 to 4 weeks, we should have better information. But I think it's going to be every day kind of coming out of it. The issue that I alluded to before is really kind of piecing all the information we're getting together from disparate sources and putting it together. But I think probably, again, 2 to 4 weeks from now, it's my logic that tells me we'll have some more consolidated opinions, and maybe the CDC giving us some commentary on it more directly. And Mary, I don't know if you have any thoughts on that as well.
No, thank you.
Well, Jeff, that's really good news that we might get reliable data that soon. Thank you.
Great questions. Anybody else? All right, then. Thank you very much, both of you, for being here, for giving us this update. Thank you. All right, let's move on to the medical staff report with Dr. Hyder.
Good evening to all. So we have a grand total of 571 with anesthesiology 32, family medicine 45, medicine 252, OB/GYN 37, pediatrics 54, radiology 26, surgery 125. The active staff is 347 and the total grand total is 371. And We have some new staff coming up. This applicant is there for the new staff is Agusher Ravi for intensivist critical care, and there is another applicant, Mikalu Yavan, PSC, physician assistant, and another applicant is internal medicine hospitalist, Pavan Patel, and then another family medicine is Susan Whitlow.
Mm.
These are the new applicants. And I have to present medical staff, honorary awards to the following physicians.
And Shri, I think we had some photos.
Yeah, if you have some photos, that would be great. Coming first to Dr. John Thomas Mehican. He's a board certified vascular surgeon specializing in minimal invasive interventional procedure. And Dr. Mehican was born and raised, go with Dr. Al Brooks. Yes, fine. Okay, thank you. And Dr. Mehican was born and raised in Chicago, Illinois, and was lived in San Francisco Bay Area since 1967. He completed his undergrad studies in University of Notre Dame and earned his Doctor of Medicine and Master of Science degree at University of Illinois. He completed an internship and residency in general surgery and fellowship in vascular surgery and tumor immunology at the University of California in San Francisco. And he was on various positions in Washington Hospital, and he was the chairman of surgery, chairman of the Division of Vascular Surgery, medical director, Vascular Center at Washington Hospital, and attending surgeon at Washington Hospital Outpatient Wound Clinic. Dr. Mehican is a fellow of American College of Surgeons, distinguished fellow of Society for Vascular Surgery, a founding member of the Western Vascular Society, and a charter member of the International Society for Vascular Surgery. And additionally, he was a clinical surgical professor at the Stanford University Medical Center. And he's a avid fly fisherman and hiker and traveler and reader also. And he joined Washington Hospital in 12/12/79, and he was in the Washington Hospital till March 1st, 2021. And the medical staff is very honored to present him with the Distinguished Award as well as the as an honorary physician for his exemplary tenure and service to the Washington Hospital and also to our community. And number 2. Next slide, please. Yes, Dr. Pipkin. Dr. Robert Donald Pipkin, he graduated from Harvard University in 1966 in general surgery and thoracic surgery, and he had gathered almost 55 years of experience. And he was the first surgeon at Washington Hospital to start our cardiac surgery program. And later on, till he retired, he was also on various positions, plus he was a quality department overlooking that. And the medical staff is honored to present him with the honorary staff member for his distinguished and exemplary service at Washington Hospital. Number 3, next slide, please. Dr. Al Brooks. The Washington Township Medical Foundation is led by a team of compassionate, dedicated, and well-respected professionals in healthcare industry and community. And our leadership reflects the commitment we have to not only to the highest quality of patient care, but accessibility and convenience as well, As part of Washington Hospital Healthcare System, our leaders are able to collaborate with some of the most experienced professionals in the Northern California. Dr. L. Brook was the president of Washington Township Medical Group and Chief Medical Officer at Washington Township Medical Foundation. In his leadership roles, Dr. Brooks collaborates with administration, physician, clinical leaders, and staff to ensure delivery of highest quality of care. Dr. Brooks did his medical school from Albert Einstein College of Medicine in New York, where he completed also residency in obstetrics and gynecology, and later at Altavate Summit Medical Center in Berkeley. He was the one who started the hospitalist program for OB-GYN in Washington Hospital and later became chair and department of OB. And he was the president of medical staff and served on the board of trustees. He arrived in Washington Hospital, started service in 2004 and established, and also he was the CMO. And medical staff is honored to present him with the honorary staff for the, for his distinguished services. Next, please. Dr. Moses Tagioff. He was a neurosurgeon with a medical degree from Grant Medical College in Mumbai, India. And also he was a Remo Cerruti Physician Award of the Year. I'm sorry to tell also Dr. Mehigan was one of that. And I forgot to mention that, sorry. And he was also, Dr. Tagioff was also past Chief of Staff, and he was for a long time OR Director. And medical staff is very honored to present him with the honorary physician for the distinguished services. These are the 4 distinguished doctors, medical staff have presented this year in 21 for the honorary physician.
And sorry, Judy. I would just add just a little bit on the history of the honorary status, just so everybody's aware. It's a very lofty title and something that is not granted very often. I don't even think there's more than 20 physicians who have been granted honorary status in the history of the hospital. I may be off by a couple, but it's a status that comes from years of dedicated service to the medical staff in the hospital and the community through clinical involvement, leadership, as these 4 physicians have shown, and really how they've left a lasting mark, not just on the medical staff, but as I said, on the hospital and the community. That to reach this status, you need to be nominated by the medical staff leadership. This is not something that you can ask to have or is easily granted. And these 4 are a great example because it was obvious to everybody that these physicians needed to be nominated for such status. So really, their careers have been impressive, but reaching this status is impressive. So I just want to explain that a little bit, what that meant.
Thank you very much. Thank you, both of you. It's nice that we have such depth of physicians that have given and contributed so much to the residents of our district, and to be able to give them this honor is a real privilege for them and for us. So thank you for making that possible. Thank you for sharing that.
Yeah, it's great.
Thank you so much.
Wonderful. Thank you. All right, let's move on to our Service League report. Debbie Ferrier, it's nice to see you sitting there.
Hi.
It's yours.
Good evening, board members. November was again a busy month with 122 volunteers contributing over 1,500 hours during the month. We are certainly not back to the pre-pandemic level of volunteer activity, but the Service League continues to increase the number of volunteers returning to service, both adults and students. We did have an orientation session last month that we opened the Anderson Auditorium for, and it was a good turnout. Not too many, and kept them COVID safe, and everybody wore masks and over 6 feet distancing. November also marked the month we were able to welcome back Masquerade $5 jewelry sale. The community members, staff, and Service League members were all very excited to shop the sale and the holiday gifts and treats. The Service League hosted the sale in the Anderson Auditorium for 3 days. We regulated the number of shoppers in the sale at any given time. So social distancing was encouraged and everybody wore masks that were hospital grade that we distributed to them. We also earned over $9,000 in commission from the sale of the masquerade, which really helps us out a lot. And we'll be able to give back to the community and the hospital, of course. I'd like to thank all the volunteers who contributed their time for the sale. I'd like to express my appreciation for Cherie Gamardo, who has been the driving force behind the masquerade sale since the beginning. And this is my report for the month. Is there any questions?
Thank you, Debbie. Yes, it was a very, very happy time. And we do thank the hospital for their support. As a volunteer working the sale, it was very rewarding to see how grateful people were to be able to come back to do something normal. So it was nice to have that support from the hospital, and Evangeline, our assistant director, made sure that she bought masks and so we weren't taking from the hospital, and we were greeting everybody at the door. We're wiping down baskets and trying to make everything as safe and as wonderful as it possibly could be. So it was a great event, and thank you, Debbie.
Thank you.
Okay, next up is our lien report. Kimberly, would you like to introduce that one?
Yes, it's my pleasure this evening to introduce Sarah Gemsky. She has been serving in the interim executive director role of Washington Hospital Healthcare Foundation since October 2020. As a consultant for CCS fundraising, Sarah has been working with the foundation team to establish best practices for major gift fundraising, including implementing a series of new philanthropic programs. Prior to CCS, Sarah served as a philanthropic consultant for Rockefeller Philanthropy Advisors, where she led the research and creation of thought leadership initiatives related to philanthropic strategy, capacity building, organizational effectiveness, and partnerships. Sarah has also served as the development manager for Mama Hope and Anza, located in Moshi, Tanzania, where she managed a team of 5 and regularly exceeding fundraising goals. While born and raised in Boston, Massachusetts, Sarah has spent much of the past decade working internationally for an array of nonprofits and organizations. She currently resides in the Bay Area and in her free time actively pursues her passion for foreign language and culture. She is fluent in French and German, and is conversant in Turkish and Swahili. And so this evening in English, she is going to be presenting her presentation on the Hospital Foundation, our charitable arm of the healthcare system, and talking about the use of lean management and tools within the foundation. So, thank you, Sarah.
Thank you, Kimberly. I appreciate that introduction. I'm going to share my screen here. So just give me 1 minute. All right. Are you all able to see the slides okay?
Yeah.
Thank you.
Your notes.
Oh, you see them as well? Okay. Let me just see if I can do this. Here. Okay, perfect. Wonderful. So thank you so much for everyone for giving us the opportunity to talk about the foundation and to share a bit about our new programs and the success we've had over the past year in implementing the new lean workflow process. So I'm gonna kick it off here by sharing a bit about the foundation. As many of you know, the foundation was started in 1983 with the support of the Service League, and our mission is to enhance the hospital healthcare system by increasing public awareness and by providing financial support. And we do this by cultivating and broadening ties with local businesses and community members on behalf of the hospital, And we also explore and create opportunities to raise funds for hospital programs, for equipment, for initiatives. And we do this through special events, through capital campaigns, through major gifts, and more. And this past fiscal year, we had our most successful fundraising year to date, raising over $3 million in philanthropic revenue. So we're grateful to all of you for your support and for the generosity of our community. And since 1983, the foundation has contributed more than $22 million to the hospital to support programming. So
Sarah,
essentially,
do you mind making the full screen of your presentation?
oh, sorry. Thanks, Sri.
No, yeah.
Yeah, sorry. I think I have to just switch screens here. Give me 1 second. I apologize for this. Let's launch this.
I can share it from here if you want.
Yeah, maybe if that's okay, Shri. Sorry, not sure why this isn't working.
Yeah, I'll share it for you. Just
Okay.
tell me it's next slide or something.
Great. All right, so we can start from slide 3 there. So the foundation is governed, sorry, one previously. The foundation is governed by a board of trustees, and we have a handful of executive officers as well. And in addition, we have a group of foundation members who help us guide our strategic planning. And we have a very small but mighty staff here at the foundation. In addition to myself, we have 2 other colleagues, Shannon Antopenko and Shobha Madagowda. So next slide, please, Shri. All right, so to help us in fulfilling our mission, the foundation has a series of key programs that help spread the word about Washington Hospital and help raise philanthropic funds. So we have 2 new programs specifically. The first that we launched in late 2020 is our planned giving program, which is a way for individuals to make a future gift through their will or estate. We also recently launched a grateful patient program called Honor a Caregiver, and this is a way for patients to make a gift in appreciation for the care that they received. They can honor a team or honor a department. And we also have a series of special events. You know, most of you have had the chance to attend our Top Hat Gala in October, our golf tournament in the spring. And we also, for the past 2 years, have participated in Giving Tuesday, which is an International Day of Giving. In addition to that, we also have major giving programs. And we've recently been working with the hospital to explore the foundation's ability to support in expanding the UCSF Washington Cancer Center. All right, next slide, please, Shri. So these programs and the mission of the foundation really align with, 2 of the hospital's strategic priorities. This would be financial improvement and patient experience. And to meet these goals, the foundation's objective is to increase fundraising through efficient donor stewardship practices and by creating new ways for the community to support the hospital. Next slide, please. So to help create sustained progress towards these goals, the foundation has worked with hospital leadership to implement the lean process, which is, as you know, is a workflow tool for improving efficiency and the quality of our work. Lean has 3 key focus areas. At its core, it's used to help ensure smooth operations. It's used to better engage staff for problem solving. And it's used to help create more visibility around improvement initiatives. So the foundation has implemented these lean principles to help us identify best practices for our work and to keep these best practices at the forefront of everything we do. Next slide, please. So lean has a series of key principles that really resonate with the foundation because they directly align with our work and they relate to everything we do. And this was the case even long before we started implementing lean. So the first of lean's key principles is called respect for the people. And this, in terms of our foundation's work, can be seen through our proper donor stewardship efforts, through our regular communication, and by working with staff to really help tell the story of the hospital. The second of their principles is transparency and accountability. And we identify with this principle through our efforts to provide clear, transparent, and prompt communication to our donors about the impact of their gift. And the third principle, feedback and data-driven, what this means to us is that we're not only constantly adapting our practices to respond to donor feedback, but donor interests and giving trends, as well as the hospital's needs, really help to inform our areas of focus. So having these principles drive our efforts has helped engage our staff, promote more transparency in everything we do, and has facilitated a feedback loop and increased engagement from our community. Next slide, please, Shri. So we did have a few challenges in adapting this process to suit the foundation's needs. And we did have many conversations with hospital leadership and lean leadership. So the lean structure at its core is designed for clinical teams. So it took a bit of restructuring to determine how we can best adapt this system to our needs. As a non-clinical team, our workflow is not as clearly defined by external systems, national benchmarks for patient care. Our work is not as externally driven. While there are best practices for foundation efforts, in terms of quality and timeliness of donor messaging and donor responses, most best practices really vary between organizations depending on their needs. We are also a very small team, as I mentioned, so we have overlapping responsibilities and shared roles. And another one of our challenges was how the foundation could best align with, the overarching hospital priorities, some of which have a clinical focus. So the foundation's role in supporting the hospital, has not always been so clearly understood within the hospital community and amongst staff. Next slide, please, Shri. So discussions on these challenges that I mentioned ultimately enabled us to adapt the lean process to suit our needs. So our use of lean and supporting tools such as visibility boards, which you can see here, help ensure that key lean principles as well as foundation principles are front and center of everything we do. And we keep them in mind in terms of all of our communication with donors. So the foundation uses 2 visibility boards. The first one you can see on the left-hand side of your screen, the frontline board. We use that for our daily meetings with staff. We meet multiple times a week. We keep track of how we engage with our community, the quality and promptness of our responses, and we regularly assess and share donor feedback. This board helps us to formalize use of best practices and keep them top of mind. So the second board you can see on the right-hand side of your screen, the process owner board. This we really use with hospital leadership to discuss the foundation's progress towards our overall major initiatives. So not only does this help us overcome any obstacles, thanks to a constant dialogue that we have with hospital leadership, but it's also a way for us to ensure that our progress is shared hospital-wide, and that everybody understands the goal of the foundation, and that ultimately paves the way for future opportunities. So next slide, please, Shri. I wanted to briefly touch on 3 of the foundation's major initiatives that I mentioned. So the first one relates to our planned giving program. And if you recall, that's a program to help donors make a gift through a will or estate. And our goal for fiscal year 2022 was to formalize and expand our planned giving program to 7 donors by the end of the fiscal year. So on a quarterly basis, we reach out to potential patients, and reaching our goal, we knew that our competition was that many other nonprofits in the area have similar programs. So we needed to expand our communication. And ultimately, since December of last year, we've conducted about 50 individual and group meetings with donors and other members of our community to talk about planned giving. And also we've been able to document 4 planned gift intentions since the end of last year, and that's totaling more than $2 million as well. So this we see as a huge opportunity for the foundation to be able to, create future financial sustainability for the hospital. Next slide, please, Shri. So another one of our goals relates to our Grateful Patient Program, which, as I mentioned, is a way for patients to make a gift in honor of the care they received. And our goal for fiscal year 2022 was to secure gifts from 50 first-time grateful patients. And so on a quarterly basis, we reach out to potential grateful patients through a brochure, and we also work with hospital staff to promote patient referrals and knowledge of the program internally. And moving forward, it is our goal to facilitate more of these meetings with key physicians and basically spread the word, as much as we can about the program and how physicians and staff can talk to patients who express an interest. And since August of 2021 alone, we've facilitated gifts from 7 grateful patients, 7 first-time donors, totaling about over $150,000. So it's another great way to bring in new donors to the foundation, and the lean process has helped us to figure out our next steps in this process. So next slide here, please, Shri. This is the last item I wanted to share with you. Another one of our key priorities relates to the hospital's plans to expand the UCSF Washington Cancer Center. And our goal is to complete major planning milestones for a potential campaign by the end of this year. And ultimately, we're looking to see how and to what extent the foundation would be able to support the hospital philanthropically in this effort. So our current project is conducting planning discussions with key staff members and community members and board members alike to help inform our planning efforts. So our next steps are to complete 30 of these interviews by the end of the year and share our initial findings with hospital leadership in early January. And to date, thanks to Lean's guidance, we've been able to develop initial case messaging around the Cancer Center needs. And we've also identified potential physician and community member partners to assist us in a potential campaign planning effort and execution. And on the last slide here, just in conclusion, we do want to thank, not only Lean leadership for its support and guidance. The foundation really resonates with Lean's key principles of respect for people, of understanding the donor community, and promoting transparency in everything we do. And because of this, it's helped us to achieve, pretty substantial success over the past year alone, again, resulting in our most successful fundraising year to date. And we're also thankful to hospital leadership, of course, and to the district board for their continued support of the foundation throughout the years. And there's a huge opportunity for us to be able to support the hospital going forward and fill in on any urgent needs like we experienced this past year. So we're grateful to all of you for your support. Thank you.
Thank you, Sarah. The foundation has been busy facilitating a lot of gifts from the community, different organizations wanting to bring food and making donations. And there's been a lot more going on with the foundation through the pandemic. And we thank you for being a wonderful part as interim director. We have appreciated your enthusiasm for your ideas, your experience, your expertise. And we just thank you. And thanks for showing that no matter what size your department, Lean can bring positive changes, helpful to make every department even more efficient and effective. And so thank you for showing how that happened for you. Any questions for Sarah? Any comments?
Sarah, this is Bernie Stewart from the board. I just want to express my thanks for what you've done. What a very, very impressive report. This plan giving and grateful patients ideas have been spectacular. I just am very, very impressed with your work. Thank you very, very much.
Yeah, I too, Sarah, want to say that I've been waiting for capability to run into opportunity. We've been lacking a lot of opportunity in the East Bay, particularly in our area when compared to the peninsula in terms of wealth buildup. But certainly it is there now, and there are many folks who have a abundance of financial resources and appreciation for the hospital. And I see your outreach, and it's heartwarming. And I just want to encourage you to keep doing that in the 80s, when we started down this road with the foundation, we didn't quite have, I mean, we had great intentions, we had great people, but we really didn't have the wealth that the Peninsula had and San Francisco had. But now we do. And taking advantage of that is something that I know that you're up to. So thank you. Thank you.
Thank you, Mike. And you, as well as the whole board, have been huge supporters of the foundation. And, you know, we couldn't get to the point we are today if it weren't for you all. And yeah, this poses a huge opportunity for us to support the hospital's growth going forward.
Sarah, I can only say thank you for your great leadership. You know, it's great to see a new vision, see the opportunities, build the programs, and enjoy the fruits of your hard work. So thank you very much for all of that.
Thank you.
We wish you the best.
Thanks.
Thank you. All right, let's move on to our finance report with Chris Henry.
Tonight we will be looking at Washington Hospital's operating and financial results for October. And moving into inpatient statistics, inpatient average daily census for the month was 9.9 higher than budget at 142. Our combined average daily census, which includes patients that are in beds for observation but not considered inpatients, that combined average daily census was 14.3 higher than budget at 152.6. Admissions for the month were 1.5% higher than budget at 782. Our patient days were 7.5% higher than budget at 4,403. Outpatient observation equivalent days came in at 329 against a budget of 191. Average length of stay for the month based on discharges landed at 5.24. We had anticipated an average length of stay of 5.16 in the budget. Still running a little high on length of stay. Looking at utilization case mix index for the month came in at 1.6. We had budgeted for just a little bit under that at 1.578 for our October. Deliveries for the month came in 19 higher than budget at 135. Our surgical cases were 38 higher than budget at 362. Cath lab cases came in at 219 against the budget of 203. Outpatient visits for the month hit 8,000 for the first time, I think, in a while. 8,014, 121 higher than the budget of 7,893. Emergency room visits continued to exceed budget at 4,209. That's 442 visits higher than we anticipated in the budget for October. Looking at the detail of surgical cases and cath lab cases, in the OR, joint replacements really drove the largest part of the surgical case variance. We had expected in the budget for joint replacement cases to begin to migrate to the Peninsula Surgery Center, but as we know, that opening has been delayed. We had expected in the budget about 31 of those cases to go across the bay. Big impact there. Our neurosurgical cases were 5 below budget for the month. Cardiac surgical cases came in 6 higher than budget for the month, and I think part of that is due to the TAVR program beginning to accelerate. Other surgical cases for the month were pretty close to budget, 5 off of budget at 152. Looking at the cath lab, again, the overall 16 higher than budget. Non-vascular interventional radiology kind of led the way, being 23 higher than budget. Neurointerventional radiology was 2 higher than budget, and that doesn't seem like a lot, but those are good cases for us. Cardiac cases in the cath lab, 9 lower than budget, and peripheral vascular were right on budget for the month. Looking at productivity, productive FTEs for the month were 98.3 higher than budget at 1,331. We had 157.3 non-productive FTEs for the month. giving us total FTEs that were 99.5 higher than budget at 1,488.3. Our full-time equivalents per adjusted occupied bed for October, which is our productivity indicator, came in at 6.09. We had budgeted at 6.84, so a good performance given the level of activity. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board format first. This is the format that we use for our audited financials. Total patient revenue for the month came in $18.2 million higher than budget at $188,287,000. Our contractuals for the month came in lower than budget at 76.68. We'd expected 77.34. Really did have a favorable payer mix in the month. Government payers in the mix were lower than budget. HMO and PPO were higher than budget, and that led to our contractual allowances being coming in at 75.8% of our gross revenue versus 75.46%. Private pay in the payer mix came in lower than budget as well, and that led to our provision for bad debt and charity ending up at 1.6% of gross revenue versus a budget of 1.88%. So good favorable numbers in our contractuals. So we ended the month with net operating revenue that was $5.4 million higher than budget at $44,327,000. Our operating expenses for the month came in just under $2.1 million higher than budget. The main drivers there were salaries and wages were $1.6 million higher than budget with our higher FTEs. Supplies came in $841,000 higher than budget, largely driven by prosthesis with those higher than expected joint cases. We again expected some of those to go across the bay. Those two were offset by favorable variances in our benefits, insurance, utilities, marketing, software maintenance, and other. So those smaller variants, but offsetting the two big ones. So we ended the month with operating income that was $3.3 million higher than budget at $2,779,000. Non-operating income for the month, we did incur a $790,000 unrealized loss on our investments. That led to a total non-operating coming in $948,000 lower than the budget, showing a loss of $846,000. But we ended the month with a good bottom line of $1.9 million against a budgeted loss of $448,000. So a positive variance of about $2.4 million in October from a GASB perspective. Moving into our FASB format, this is the format that is used and reflects some adjustments that the financial markets might make to our financials to make us comparable to FASB organizations. First thing we do is we reclass our revenue bond interest expense out of the non-operating category up to operating expenses. We moved about $572,000 this month to come up with operating expenses from a FASB perspective that were $2.1 million higher than budget at $42,120,000, and giving us operating income from a FASB perspective that was $3.3 million higher than budget at $2.2 million. We then make some adjustments to our remaining non-operating income. What we do there is eliminate our GO bond interest expense and the related tax revenue that services those bonds, and our unrealized loss on our investments. FASB does not recognize those things. So we end up with non-operating income of $234,000 from a FASB perspective, and a total bottom line of a little bit over $2.4 million almost $3.2 million higher than expected. Taking a quick look at earnings before interest, taxes, depreciation and amortization, our EBITDA format. This gives us an idea of the income that our operations are generating from a cash standpoint. First thing we do is we pull out our depreciation expense from operating expenses, because depreciation is a representation of cash flows that have already occurred. So we end up with, after making that adjustment, EBITDA of $6.7 million. We then take a look at our non-operating income before interest expense of $885,000, and in total, our operating and non-operating operations provided about $7.6 million in income, again, for funding capital expenditures, program development, and the debt service on our bonds. So that's the results of October. Are there any questions on October? Okay.
Thank you very much, Chris. All right, so let's go on to the hospital operations report with Kimberly.
All right, thank you. You're going to hear a number of the same themes that we heard from Chris for October, for November of 2021. As you can see, gross revenue of $181.6 million for November was above budget by $16.9 million, or 10.2%, and above November of 2020 by $18.7 million, or 11.5%. Inpatient gross revenue of $102.1 million was below budget by $5.1 million, or 4.8%. Although admissions and our average length of stay were higher than budget, the driving factor in lower inpatient revenue was again due to lower OR cases, really driven by the joints, and then also lower inpatient cath lab volume. Looking at outpatient gross revenue of $79.5 was above budget by $22 million, or 38.3%. Just so everyone is aware, in November we had 13 COVID-19 discharges, representing just 2% of our total discharges. This is lower than the last month, and one of the lowest numbers that we've had in terms of COVID-19 discharges since the onset of the pandemic. And I do want to say we did hit 1 day for a short period of time. We had no COVID inpatients in-house, so that is the first since the onset of the pandemic. All right, moving on to key census statistics. Our average length of stay of 5.43 was above the budget of 5.26 by 0.17, or 3.2%, and longer than November of 2020 average length of stay of 4.99 by 0.44, or 8.8%. And again, there were more, if you're looking at comparison with 2020, there were more inpatient joint cases in the prior year, which does have that downward impact on length of stay, because the average length of stay for inpatient joints is about 1.5 days. Moving on to observation, outpatient observation days were 147, or 72.1% above the budget at 351 days, and were 145, or 70.4% above November of 2020. Inpatient average daily census of 136.9 was above the budget of 128.6 by 8.3, or 6.5%, but was 5.4, or 3.8% below November of 2020. So if you look at the combined average daily census of 148.6, it was above the budget of 135.4 by 13.2, or 9.7%. But was about 0.6 or 0.4% below November of 2020. Just looking at our discharges in November, there were 7 discharges with a length of stay greater than 30 days. That ranged from 32 to 71. And if you excluded those long lengths of stay, our average length of stay was at 5. I will say that we do still have in-house, at the end of the month, we have 7 patients with lengths of stay over 30 days, and they range from 32 to 189. So we're continuing to work on discharges where appropriate. Moving on to admissions trends, admissions were above budget by 6 or 0.8%. The increase in observation days that I just spoke about results in fewer admissions and estimated about 27 to 49. We're also, as Chris has said, and I'm saying too, we're continuing to see the shift in joint cases from inpatient to outpatient at a higher rate than we saw in the prior year. In the month of November, only 4% or 6 cases of the total joint replacement cases were inpatient compared to 40% or 51 cases that we had budgeted. Moving on to patient days, our admissions were above budget by 0.8% and our average length of stay was higher than budget by 3.2%. And this resulted in patient days of 4,107. This was above the budget by 6.5% at 4,107. Moving on to our surgical trend, total surgeries in November of 380 were above budget by 48 or 14.5%. Surgeries were 24 or 6.7% above November of 2020. Looking at the breakdown, inpatient surgeries were 31 or 19.5% below budget at 128, and outpatient surgeries were 79 or 45.7% above the budget at 252. And again, outpatient joint cases, as we had mentioned, were budgeted to begin migrating to the Peninsula Surgery Center in October, but now it is delayed, and we're expecting probably open up around the first quarter of calendar year 2022. So now moving on to the breakdown of surgical activity. You can see our joint replacement surgical cases were above budget by 37 or 28.7% and were 12 or 7.8% above November of 2020. Neurosurgical cases were below budget by 4 or 16% and were 2 or 8.7% below November of 2020. Cardiac surgical cases were right on budget at 13 cases and were 9 or 225% above November of 2020. All other surgical cases combined were above budget by 15 or 9.1%. Looking at our cath lab trend, cath lab cases for November of 183 were 7 or 3.7% below budget and 1 or 0.5% below November of 2020. Cath lab inpatient cases for November were of 86 were 18 or 7.3% below budget, and cath lab outpatient cases for November of 97 were 11 or 12.8% above budget. Looking at the breakdown of our cath lab activity, our cardiac cases were below budget by 9 or 10.3% and 8 or 9.3% below November of 2020. Non-vascular interventional radiology cases were above budget by 1 or 1.8% and 16 or 40% above November of 2020. Our peripheral vascular cases were above budget by 6, 14.3%, but 6 or 11.1% below November of 2020. And then lastly, neurointerventional cases were below budget by 5, 83.3%, and 3, 75% below November of 2020. Moving on to deliveries. Deliveries for November were at 115, which was above budget by 5 at 4.5%. I will say that we did slow down towards the end of November, but we have our first week in December has been very busy in terms of deliveries, so we'll have to see if that trend continues to continue throughout the month. Moving on to our non-ER outpatient trend, our non-emergency outpatient visits of 7,553 were above budget by 277 visits or 3.8%, and were above November of 2020 by 1,023 or 15.7%. This was primarily driven by X-ray visits were above budget by 230 or 14.9%. Our cardiac rehab visits were above budget by 101 or 20.1%, and really that trend is trending a great deal with our increase in our cardiac volume. Our EKG visits were above budget by 40 or 19.5%, and then this is offset by our lab visits, which were below budget by 166 or 5.8%. Moving on to our emergency room visits, we experienced 4,241 emergency room visits, which were above budget by 602 or 16.5%. And they were above the same period last year by 880 or 26.2% visits. So our emergency room visit has pretty much gone back to where we were pre-COVID. Now looking at our gross revenue, our cath lab cases were below budget, as I mentioned, by 7 or 3.7%, driving cath lab revenue down by $321,000 or 2.7%. Our deliveries were above budget by 5 or 4.5%, and there were higher charges per case, driving birthing center revenue up by $454,000 or 16%. And we did have 29% of the cases were C-sections versus our budget of 24%. Patient days were above budget by 249 or 6.5%. This drove room and board revenue higher than budget by $1.6 million or 5%. Emergency room visits were above budget by 602 or 16.5%, and the level mix was higher. So that also drove the emergency room revenue up by $2.3 million or 23.9%. Total surgeries were higher than budget by 48 or 14.5, but there were more outpatient cases and fewer neurosurgery cases as mentioned. So surgical services revenue was up by $4 million or 12.4%. And then lastly, outpatient activity drove ancillary services revenue above the budget by $8.9 million or 11.6%. Moving into our payer mix, again, we had another potentially favorable month in terms of our payer mix. As you can see, government-sponsored patient revenue made up 70.7% of total gross revenue. This is lower than budget by 1.5% and lower than the prior year by 1.5%. HMO was 3.1% of gross revenue, which is slightly above budget of 2.7%. And higher than the prior year percentage of 2.2% of gross revenue. Our PPO was 25.1% of gross revenue, which is above budget of 23.1% and higher than the prior year percentage of 23.5% of gross revenue. Our private pay was 1.1% of gross revenue, which is below budget of 2% and lower than the prior year percentage of 2.3% of gross revenue. Looking at our preliminary net patient revenue for the month of November, before any other supplemental revenue, it is about $40.9 million compared to a budget of $37.4 million. So overall, once again, a good favorable payer mix for the month of November. Moving on to our productivity indicators, our productive FTEs were above budget by 72.8 or 6%. At 1,284.7. Our non-productive FTEs were above budget by 19.7 or 9.8% at 220.4. Our total FTEs of 1,505.1 were above budget by 92.5 or 6.5%. If you look at our productivity indicators, our productive FTEs per adjusted occupied bed of 5.28 were lower than the budget of 6.14, 14%, and lower than the prior year at 5.66 or 6.7%. And our total FTEs per adjusted occupied bed of 6.18 were lower than the budget of 7.15 or 13.6%, and lower than the prior year at 6.64 or 6.9%. So again, we're working on managing to our volume. Moving on to the outpatient statistics, Washington Township Medical Foundation clinic visits were lower than budget in November by 222 or 1.4% at 16,155. This was 1,385 or 19.4% percentage visits above November of 2020. And the variance to budget was primarily driven by some of our physicians taking time off due to the holidays. Looking at our DevCo outpatient visits of 2026, we're below budget by 43 or 2.1% for the month of November, but 2.7% above the November of 2020 visits. Looking at the breakdown, Washington Outpatient Rehab Center was down 124 visits. That's mainly due to having 2 open positions for physical therapists that we have now just recently have filled them, and they have started. And also, we've been recruiting for a new clinical director. Our Washington Radiation Oncology Center treatments were up by 10. Our Washington Outpatient Surgery Center visits were up by 86. And then Ohlone College Student Health Center visits were down by 15, and hybrid classes are continuing. So they still have students that are not coming on at this point. All right, moving on to key financial statistics. Days cash on hand for November ended at 165 days, an increase of 2 days from last month. Our days of gross revenue and accounts receivable were 69. And basically this represents an increase of 2 days compared to the prior month. But the main impact of this was due to the holiday that we had at the end of the month with Thanksgiving. And this is a time when many of the payers have closed and they've slowed down their operations. And so looking today at our AR days, they are at 67, which is consistent with the prior month. And we are going to be seeing the same impact in terms of payers either closing or slowing down their operations, which is going to impact our days in AR as the December holidays come. There was $1 million in charity care adjustments in the month of November. There were 3 high dollar accounts totaling over $900,000 that makes up this $1 million in charity care. All right, so that is my report for November of 2021.
Thank you, Kimberly. Any questions for Kimberly? Any comments? Okay, thank you. For our next agenda item, under consideration is adjustments to the base salary for the Chief Executive Officer. So I would like to ask Dr. Nicholson, as the outgoing president, to chair this portion of the meeting, including the next 2 agenda items as well, given that we will be discussing the performance of the Chief Executive Officer during his time of tenure as president. So Dr. Nicholson, it's all yours.
Thank you very much, Madam President. It's a pleasure to conduct this portion of the meeting where we address the employment agreement and stellar performance of our CEO, Kimberly Hartz. We have 3 action items to consider. First, we need to consider whether to adjust Ms. Hart's base salary. The second action item is that we need to consider is whether to give an award of an incentive award for fiscal year ending June 30th, 2021. And the third action item is whether we will consider extending the term of her employment agreement. At this point, I'm going to ask Paul Kozachenko, the hospital's legal counsel, to make a presentation. Paul?
Good evening, Dr. Nicholson. Good evening, board members. Congratulations, President Yee, on your election. We look forward to working with you. By way of background, the Chief Executive Officer is the only employee of the district who is hired directly by the board. Annually, the board reviews the CEO's performance as required by the employment agreement. As part of that process, the board considers data provided by an independent healthcare compensation consultant and all other factors the board considers important. The board then decides whether or not base salary should be adjusted and whether to make an award of incentive compensation. The board also considers whether to make any other revisions to the Chief Executive Officer's employment agreement. The district has a long-standing philosophy of wage parity for all employees, which includes the CEO. Wage parity means that the CEO is not paid at the top, nor is she compensated towards the bottom of the scale. The district's compensation philosophy of marketplace parity establishes a base salary for the CEO at around the 65th percentile of her peer group, and total cash compensation for the CEO in the range of the 75th percentile of her peer group, with a maximum possible incentive award of 25% of base salary. Benchmarking executive compensation based on peer group data is standard practice for establishing reasonable compensation for executives working for nonprofits. The district's compensation philosophy reflects the district's long-standing philosophy of wage parity for all employees. Annually, the board engages Arthur J. Gallagher and Company, I will refer to them as Gallagher, to provide a report for the board's use in deciding compensation for the CEO. Gallagher is a leading healthcare compensation consultant in the United States. Hundreds of healthcare systems use Gallagher's services as an independent consultant to satisfy internal revenue regulations for determining a range of reasonable compensation. The Gallagher report assesses the competitiveness of the cash compensation for the Chief Executive Officer. Appendix A of the Gallagher report includes a list of similarly situated California organizations in Gallagher's proprietary database. The Gallagher report for the current fiscal year is attached to my memo to you and is in the public record and is dated September 2021. The Gallagher report provides the board with appropriate comparability data in accordance with IRS regulation. In its report, Gallagher reviewed the background data on the district for the 2020, 2021, and then the 2021-2022 fiscal year. Gallagher then compiled data on compensation levels for California healthcare systems, regressed for size using data from Gallagher's proprietary database and salary surveys. Based on the foregoing, Gallagher prepared market charts summarizing compensation survey data at the 25th, the 50th percentile, and the 65th percentile for the California peer group. The charts are prepared for both base salary and total compensation so that you can consider the effect of a potential incentive award. To remind you, the prior board action, the board approved the employment agreement for Ms. Hartz at a board meeting on June 12, 2019. At that time, the board set Ms. Hartz's base salary at 80% of the 65th percentile in recognition that while Ms. Hartz had substantial experience and knowledge given her years of service as a senior associate administrator, she had not yet served as a CEO. The board set her base salary at 80% of the 65th percentile, or $712,000. Ms. Hartz was eligible to earn an incentive award of 25% of her base salary based on achieving performance goals. According to the employment agreement, the board was due to consider an annual base salary adjustment and incentive award by October 31st, 2020 for the fiscal year ended June 30th, 2020. Due to the impact of the COVID pandemic, Ms. Hartz requested that the board defer any consideration of a base salary adjustment and an incentive award until after the end of the fiscal year, June 30th, 2021. Ms. Hartz's base salary has remained the same since July 1, 2019, and she received no portion of the incentive award for the prior fiscal year. So you'll be considering three different actions, as Dr. Nicholson, you have indicated. For the first one would be a base salary adjustment. The chart on page 9 of the report shows that Ms. Hartz's current salary of $712,000 compared against the peer group at the 25th, the 50th, and the 65th percentiles. Her current salary is 4% below the 25th percentile, and 17% below the 50th percentile, and 25% below the 65th percentile, which is the board's target for base salary. As the Gallagher report notes, as Ms. Hartz acquires experience as the CEO based on her performance, it would be expected that her base salary should move closer to the 65th percentile. As to the incentive compensation for the prior fiscal year, Ms. Hartz's current employment agreement states that she is eligible to earn an incentive of up to 25% of her base salary. Page 14 of the Gallagher report shows that if the board chooses to award the full 25% of base salary, the CEO's total cash compensation for the fiscal year ending 2021 would be 3% below the 25th percentile and 18% below the 50th percentile. Historically, the board has considered a number of factors in determining the amount of the incentive award portion of the CEO's compensation. These factors include consideration of various accomplishments during the past fiscal year. The board has recently received a separate memorandum from the CEO, which includes a list of accomplishments for the board's consideration in determining an incentive award. Based on Mrs. Hartz's current base salary, the board can decide to make an award of incentive compensation between 0 and 25% of her base salary, which would be $178,000. The last item is the extension of the contract. In addition to reviewing cash compensation, the board typically agrees to extend the CEO's employment agreement to maintain a 4-year term. Since the contract was not extended last year, the board would need to extend the contract by 2 years to maintain a 4-year term. So the possible board actions tonight are, in summary, consider a base salary adjustment based on performance and existing compensation philosophy. Number 2, an incentive award of up to 25% of base salary. And 3, an extension of the term of the agreement by 2 years. And that concludes my introductory remarks, Dr. Nicholson.
And thank you very much, Paul. I think it's important for the public to know that Paul's memo to the board, which he read from, as well as Kimberly Hart's memo to the board, as well as the Gallagher report, are available on the hospital website. Also included on the hospital website is the CEO's current contract, and will also include any adjustments that the board may choose to make tonight. So just so that the public is aware that this is public information. So our first action item is regarding the CEO base salary. The first issue is to consider is whether to adjust Ms. Hart's base salary. The memo from Paul provides background information, includes the Gallagher report with potential salary ranges based on comparable California peer hospitals. I will exercise my prerogative as interim chair to give you my initial thoughts. I think that adjusting her base salary to the 50th percentile is the appropriate decision for this board, and I will explain why. Our compensation philosophy is to set the CEO's base salary at the 65th percentile. When we appointed Kimberly on July 1st, 2019, we decided to set her base salary at 80% of the 65th percentile. We did this because although Kimberly had extensive experience as a senior administrator, she did not have experience as a chief executive officer. I expected, and I think all of the members of the board expected, that as Kimberly gained experience and met our performance expectations, that the board would adjust her base salary incrementally so that we could move her close to the 65th percentile, which is consistent with our compensation philosophy. But how things change. Little did we know how our world would change in March of 2020 when the COVID-19 pandemic hit with full force. In my view, since her appointment, and especially with regard to the challenges facing the district in dealing with the pandemic, Kimberly's leadership and performance have been exemplary. Therefore, I propose that we make a significant adjustment to her base salary to get her closer to our ultimate goal. We also need to keep in mind that we deferred any action to adjust compensation last year in October of 2020. This was understandable given that we were in the midst of the pandemic, but nevertheless, Kimberly did not receive any consideration for an adjustment in her base salary, despite the fact that her employment agreement provided for such consideration. Currently, Kimberly's base salary is below the 25th percentile. I would suggest that we consider raising her base salary to the 50th percentile, which would set her base salary at $861,000 annually, as shown on the Gallagher report. I think there's clear-cut reason for doing so, and I will highlight just a few points, and following that, I will ask the other board members to render their opinion and consideration. So I'm going to highlight 4 points, which I think highlights the motivation for raising Kimberly's base salary. The first has to do with the response of the institution to the COVID crisis. There were several complex elements involved, including securing PPE, creating negative air pressure rooms throughout the house to accommodate expected COVID patients. All of those things were done early on so that when the COVID surge did hit, we had the facilities available at that time to manage those patients safely, both for the patient's safety as well as for the safety of the employees, staff, and medical staff. This was done in an exemplary fashion. Further, great work was done to acquire the necessary therapeutics and later the vaccines to address our COVID response. Probably the most interesting thing for me was to observe the performance of Kimberly and her leadership team as they approached this problem. Daily meetings were held. There was great communication. Kimberly fostered the attitude and culture of collaboration throughout the house, breaking down barriers and being very agile in the way that we responded to the COVID crisis. Without such leadership, I think we would have been in a very bad state. But instead, given her leadership, we have survived quite well through the COVID crisis. So that's my first point. My second point is having to do with our vaccination program. I think it would be difficult, no, actually it'd be impossible to overstate the stellar performance and legendary performance of our COVID vaccination clinic. When the COVID vaccines became available, Kimberly, her leadership team responded very quickly to assemble the necessary resources, procure the vaccines, and most importantly, open the doors of Washington Hospital to everybody in the community to receive the vaccine in a timely fashion. It's hard to think of how great a relief this was to the many people of the township to be able to receive the vaccine and be afforded protection from COVID. The third item I'd like to highlight is that Kimberly and her leadership team brought about the fruition of the relationship between UCSF and Washington Township Healthcare District to create the Warm Springs Clinic. This will bring great facilities and talent to a growing area in our community. And the fourth item may be the most important in the long run, and this has to do with Kimberly's attention to building a culture of safety and collaboration within the hospital, which will result and continues to make progress on building a culture of safe environment of care and the highest quality of care to our patients. So at this point, I'd like the other board members to comment if they choose to. Following that, we will open this to a public hearing and then address the motion. So if there are any other board members who'd like to speak, please go ahead.
Okay, I just want to say I have been, I can't say that I've been surprised by what Kimberly has achieved in these last 2 years, even in the face of the challenges that we've had with COVID. There's an old saying in terms of leadership. It's all about management by walking around. Kimberly is, I know that she is out in the facility, and she's appreciated by all of our doctors and nurses and employees, and that is a form of leadership that is sadly missing in so many different businesses that I'm familiar with in my business career. And it's heartwarming to me to see the engagement that Kimberly has with all of the constituents that that we depend on, and the patients in the hospital really depend on. And these meetings during the COVID crisis is just a part of what Kimberly's all about, and her style of management and leadership. And I really appreciate it, and I acknowledge it. And I tell you, it's sadly missing in a lot of the different businesses that I'm familiar with in my life. So I think that when we decided initially to go at the 80% of percentile that we were deciding, I think that was kind of a okay, let's see how this all is going to work out, given the fact that there wasn't a history of leading other hospitals. And I can tell you this much: I am so pleased with what I've seen in that I'm somewhat embarrassed that we even did that, but I'm happy to support this adjustment in the salary range that you've been suggesting, Dr. Nicholson. Is well deserved, and I think we are on our way to building a stronger management team and a better future under Kimberly's leadership. So that's my 2 cents, so to speak.
That was a good 2 cents. Very good 2 cents. Thank you. Thank you, Paul, for your background, for the explanation and the comments, and Dr. Nicholson for your rationale, for your thoughts on what would be the wisest thing to do for Kimberly at this time. I too have appreciated her leadership, the way that she's modeled a real servant's heart in the way that she leads. She cultivates a spirit of collaboration. She'll be the first to credit the team instead of take any credit for herself. And I just appreciate that style of leadership. She gathers people around, she mobilizes their strengths and encourages them. And we've seen it not just with COVID, but she was hit very early on with some unusual circumstances that I haven't forgotten is I began pretty much when she did as well. And I was amazed at how unflappable she was. And so I appreciate her leadership, and it's such a privilege to rub shoulders with people of this caliber. So I thank you for your comments.
I'd like to second everything that's been said. At the same time, I really don't think it's an exaggeration at all to say that this last year has been the greatest challenge in the history of the hospital. This COVID coming at a time when it did could easily have destroyed the hospital. The costs and the dangers and all of the things involved in that could easily have caused major, major troubles to our healthcare system. Instead, we seem at this point to be coming out of it stronger and with a good future ahead of us. An area that has stuck out in my mind has been the vaccination clinics that we've been able to run. I have many friends, many associates in the Tri-City area who were unable to get their vaccinations from their care providers. And the hospital stepped up and did that. Just Monday night over at the Newark tree lighting, the hospital provided a vaccination clinic for people to come and get vaccinated. And when I got there for the evening, I saw this long line of people waiting to get in, and found out that well over 160 vaccinations were given that night to the citizens and people that attended that event in Newark. That's tremendous progress against this horrible disease that we're all facing at the moment. Another area that has stood out to me significantly is our work with UCSF, where we're doing cardiothoracic work and pediatric fellows coming to the hospital, and of course the clinic down in Warm Springs. I just am very, very pleased with where we've been. There's an area that hasn't been talked about very much, and in the midst of all of this, in the midst of all these challenges, we've received the magnet designation for our nursing program. That puts us in the top 9% of hospitals in the entire nation. Tremendous accomplishments. I appreciate what Kimberly and her staff have done to protect the hospital and get us moving along in a positive way. I would support the motion made here tonight from Dr. Nicholson. I think it's fair and appropriate that we make that 80% designation.
Thank you, Mike, Jeannie, and Bernie. At this point, I would like to open this action item to a public hearing. This is action item A, base salary adjustment. So is there anyone from the public who would like to address the board regarding this action item? Hearing none, I will now close the public hearing on this action item. And I'll ask the board members if any of them would like to make any further comment before we hear a motion and take any action. Okay, so if I could have a motion on action item A, base salary adjustment.
I hereby move that the board increase the chief executive officer's base salary to $861,000, which is around the 50th percentile of the California peer group, and that this adjustment shall be effective as of July 1st, 2021.
Thank you. We have a motion. Do we have a second?
I second. I second.
Thank you. A second from Director Wallace. Dee, can we have a roll call vote, please?
Director Z, Director
Aye.
Yi,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen, Director Nicholson.
Aye. Motion passes. Ms. Hart's base salary is adjusted to 861,000 effective July 1. So action item B is the award of incentive compensation. This next issue for us to consider is whether to award Ms. Hart's incentive compensation. Her contract says that we can make a discretionary award up to 25% of her base salary, or $178,000. Again, I exercise the prerogative of acting chair to give you my thoughts, and I feel that an incentive compensation of $100,000 is appropriate. Here are my reasons. For reasons I've already stated, Ms. Hart's performance over the past 2 years has been absolutely stellar and outstanding. She has led the district through perhaps the most significant health crisis this country has seen in our lifetime. It is largely due to her efforts that the district has pulled through the crisis as of this point and is on the path to handle whatever may come ahead in a very stable and strong position. In addition, Ms. Hartz has met or exceeded the performance goals that we set for her last year, despite the challenges presented by the pandemic. In her letter included with today's material is a list of her accomplishments. I'm just going to cite 2 of them, and I would invite some of the other board members to comment on others. But the first one would be the financial performance. Our financial performance based on our EBITDA actually exceeded our expectation despite the challenges of the COVID crisis and all of the expenses and difficulties that were encountered therein. The second is the passage of Measure XX, the bond campaign, which allows the hospital to continue its plan to deal with seismic safety so we can continue operations beyond 2030. There are many other things highlighted in her memo, as well as many other things that she did not elaborate in her memo, but it goes without saying that her accomplishments have been outstanding. By my accounting, Ms. Hart's performance does warrant an award of 25% of her base salary, of which would be the $178,000. However, we can't ignore the financial impact of COVID on the district's finances, so I think we must reward achievement, but we should not award the maximum, even if all of us think it is well deserved. I am thinking of an appropriate amount that would reward Kimberly, and I feel that 100,000 is significant, but also mindful of our financial situation. So at this point, I would invite other board members to comment on Kimberly's performance as well as the incentive compensation award.
Well, I think that one of the things that you touched on, Dr. Nicholson, is the fact that the bond measure passed that Kimberly was so influential in making happen. It's not just the participation in that particular campaign. It is the fact that the public supported the measure, and not just for this particular phase of the rebuild of our campus, but it is the third bond measure that the residents of the community have supported, going back to 2004 or 2012, all of which Kimberly had was a huge participant in, and as I said, it goes beyond any of the participation in getting the awareness out there to the community about the importance of making sure that we had a viable hospital in 2030. That is an awareness thing. That's a political thing, and Kimberly's participation in that and leadership in that was invaluable. But what really made those measures successful is the ongoing 25 plus year commitment to the patients and the resulting love that the residents of our community have with the hospital, which is something that was, I think that was well-deserved because of the treatment that the hospital has always been there and provided for our residents. So I think that it's well-deserved. I think I would support more than that, but given what you've said, it's something that I think is a reasonable kind of somewhat of a compromise. I look forward to better years. I mean, this year is quite a tremendous turnaround in terms of the financial performance once we've gotten out of this COVID. We are positioned in a really strong way to serve our community and take advantage of all of the resources and attributes that we have with our medical staff and with our employees, and Kimberly being the orchestra leader. I have a lot of faith that this year is going to be even a better outcome from the COVID years, and so I just want to say that it isn't just, to me, in my mind, it's just not about the recent performance. It's all about the ongoing dedication, and of course I'm really connected to the bond campaign and Measure XX, because I know without that passage, the future of the hospital would have been very well constrained. But now we have a clear path forward. We have the funds necessary to complete the campus that we all want and what our community deserves. And I think Kimberly has a huge part in that. And I thank you. I thank you for that.
Mm-hmm.
Thank you, Mike. Jeannie?
Well, as we considered all of this compensation and looked at all the metrics, and she met and exceeded so many of our expectations, but something that was not included that I feel was almost invaluable to me. And I think it's just because as a volunteer of the hospital, I so appreciated her valuing the fact that for the first time in the 60+ years of the Service League, volunteers were kept out of the hospital. And she took the time with Evangeline, our assistant director, to have Zoom meetings to keep the volunteers engaged and informed, and to keep them in the loop of what was happening, to make sure that they got opportunities for vaccinations. And that was so valuable to me as a community member, as a volunteer, as someone who cares about the hospital, and to know that even though we weren't present in the hospital, that we were not forgotten, that we were still a valuable team member as part of the healthcare team of Washington Hospital, and continuing to get that information and to be kept in the loop and to be protected and to still feel valued even though we couldn't serve. I think I speak for all the volunteers that it was very meaningful and had such great value, but wasn't considered really included in our consideration for her compensation and for all that we're discussing today. But I just wanted to say that had great value to me.
I agree with all that's been said. I'm very supportive of Bill's recommendation on the incentive compensation. I agree with Mike that it's too bad we can't offer more in that regard simply because of the accomplishments that are there. But I think this is prudent and appropriate. I'd like to just mention one other small little item. I guess not really such a small little item. When COVID became a problem, in a very rapid manner, the hospital was able to convert 74 rooms into negative pressure rooms, where that disease could be totally managed and totally isolated. 74 rooms, that's a significant accomplishment in managing and changing and rooms that into that kind of a situation. That's just one little area where a significant accomplishment really helped us work with this COVID situation so that we can help the community and isolate those that are infected and make real progress on it. I thought that was a wonderful accomplishment. And I remain supportive of the motion that Bill has made on that incentive compensation.
Well, thank you very much, Mike, Jeannie, and Bernie, for your comments. Mike, with respect to the longevity of Kimberly's performance here at the hospital, you're exactly right that it has been leadership in her senior administrative position and now as CEO that has helped the public have the confidence to vote yes on Measure XX, and that is essential, as you mentioned, for our future. So at this point, I'd like to open this action item, item B, the incentive compensation award, to the public for a public hearing. So is there anyone from the public who would like to address the board on this action item? Hearing none, I will now close the public hearing and ask if any board member would like to make any additional comments. And if not, I'll entertain a motion on item B, incentive compensation award.
I hereby move that the board award incentive compensation to the CEO based on the CEO's outstanding performance in the amount of $100,000.
Thank you. We have a motion. Do we have a second?
Second.
Second again from Director Wallace. Thank you. And Dee, could you call a roll call vote, please?
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen, Director Nicholson.
Aye. Okay, motion passes and an incentive compensation award of $100,000 for this past year is awarded. Okay, now we'll come to the third action item tonight, which is probably the easiest and most straightforward, and that is whether to extend the term of Kimberly's employment agreement. So typically at this time, when we adjust the contract compensation, we also consider a motion to extend the term to 4 years. So at this point, I would like to see a motion that would extend Kimberly's term of her employment agreement to a new effective term beginning July 1, 2021 through June 30th, 2025. Obviously, I think this contract extension is very well deserved. But more importantly, I think the community is best served by retaining Kimberly in this role for 4 additional years. So I'll request any comments from any of the other board members regarding this action item. I guess it goes without saying.
It's a no-brainer.
We're all in agreement. Okay, well, at this point, I will go ahead and open the public hearing regarding action item C, extension of term of employment agreement, and ask if anyone from the public would like to address the board on this item. I guess the public is quiet on this as well. We all agree. So I'll close the public hearing at this point and ask if any board members would want to make any additional comments. And if not, I will ask for a motion on item C.
I hereby move that the employment agreement be extended for 2 years for a new term beginning July 1st, 2021 and ending June 30th, 2025. And the president of the board be authorized to execute an amendment to the employment agreement consistent with the actions taken here tonight.
Thank you. Do we have a second?
Second.
A second again from Director Wallace. Thank you, Dee. Can we have a roll call vote?
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Epen, Director Nicholson.
Aye. The motion passes and Kimberly's contract is extended through June 30th, 2025. That's really good news. And congratulations, Kimberly. You've heard a lot of good things tonight. You must be, maybe you're blushing a little bit behind that mask. Hard to tell. But I'd like to give you an opportunity to say anything you'd like to the board and to the public.
I do appreciate it very much, and I do want to thank the board for their kind words and recognition, but more importantly, basically for your support. This has been a challenging time, and I think everybody knows it. And I do want to say that our success as a healthcare system is truly a team effort. It has been and can be directly attributed to the leadership of our managers, our staff, and our physicians. And it's their true hard work, resilience, and basically compassion that has gotten us to where we are today. So really the thank you is to everybody that has been part of the team. And I truly believe that. And I think really for me, what I'm most proud of is being able to sit here today and know what we've gone through and know that there's challenges behind us, but there's also, I know, more challenges ahead of us, but that we can say, looking back, that we did meet the healthcare needs of the community when they needed us the most. And to me, that is what I'm most proud of. And I think that it has shown what we can do together to serve this community. And I think that there will be more challenges ahead of us, but that we will be able to continue to put in place the foundation that is needed to make this healthcare system successful for the next 60 years. So I do want to thank everyone. I want to thank the board for their support, and I thank you, Dr. Nicholson, for this past year as president, and also look forward to working with Jeannie going forward. And all of the board has been amazingly supportive. But again, I want to thank the whole team, and that is truly, it has been a team effort to get us where we are today. So thank you to everybody.
Thank you, Kimberly. I think you hit on the point, is that this is a team effort, and I really thank you for fostering that culture of collaboration and transparency and interaction. By working together, we'll overcome those obstacles. We don't know what they are. You know, things can pop up, and they will. But with your leadership, I'm confident we'll be able to get through those. So I want to thank you, Madam President, for allowing me the honor to conduct this segment of the meeting, and I will turn the gavel back over to you.
Thank you very much. Thank you. Thank you. Yes, we will always want to come out stronger than before, and challenges only go to prove that that can happen when you work together. All right, so let's move on with the agenda. Any announcements, Kimberly?
I do have a few announcements, so
Okay.
we'll get through these. I do want to talk about an important topic, which is Employee of the Month for December of 2021. And that's Sharon Hoffman, who is an LVN3 with Wound Care Clinic. So after working at the Masonic Home for several years with the encouragement from her husband, Fremont resident Sharon Hoffman took a leap of faith and joined Washington Hospital in 2000. She began as a certified nursing assistant, and during the next 20 years, Sharon grew both personally and professionally, as she took classes and challenged the board to successfully sit for the exam to become a licensed vocational nurse, an LVN. Working in the outpatient Washington Center for Wound Healing and Hyperbaric Medicine, Sharon has learned both clinical and administrative aspects of the department. She assists with patient care, is one of the backup techs for the hyperbaric oxygen therapy unit, works the front desk, and orders supplies to keep the department running smoothly. Because of her wide range of duties, Sharon gets to know most of the wound care patients. She says, "There is such a joy in helping a patient heal. Sometimes we have to work to develop their trust, but then they feel like we are family. Working in the wound care clinic has been a special benefit. The special benefit has been seeing patients several times as they journey towards improved health. During that time, Sharon and her co-workers develop bonds with the patients. In addition to appreciating all of her co-workers, Sharon feels grateful to be part of the Washington Hospital healthcare system. She notes, quote, "It's awesome to be part of an organization that does so much good for the community." End of quote. Her manager would say it's awesome to have someone like Sharon Hoffman as part of her team. Congratulations, December Employee of the Month, Sharon Hoffman. Then just moving on quickly, just a couple of announcements around our outreach activities and health promotions. We've continued our vaccination clinic, and as of Monday, December 6th, a total of 76,961 COVID vaccine doses have been administered. On November 3rd, we began vaccinating children ages 5 to 11 years old. And as of Friday, December 3rd, a total of 1,397 vaccinations have been administered to this group. And I know, I think Dr. Stewart also mentioned at the Newark tree lighting ceremony, we did have one of our vaccination clinics, and we did give over 165 doses to the community. Then we also did on November 10th and December 1st, we vaccinated 39 students and family members at Little Apples Learning Center in Fremont. In terms of our community outreach and education, on Thursday, November 11th at 6:30 p.m., Dr. Jet Liu, our orthopedic surgeon, presented "Why Does My Ankle Hurt? Causes and Treatment of Ankle Pain." It was on Facebook Live and YouTube. We had 189 community members participated in the live event. And then since then, 1,166 additional people accessed the presentation. We also had on Wednesday, November 17th at 6:30 p.m., Deborah Crisp and Heather Heath, both with respiratory therapy, presented Keeping Your Lungs Healthy, and that was on Facebook Live and YouTube. 166 community members participated in the event, and then since then, 1,044 additional people accessed the presentation on one of our social media channels. On Tuesday, December 7th at 6:30, Dr. Sarah Wortman, vascular surgeon, presented Healing Foods Are Good Choices in Our Health. 84 community members participated, and 201 since that time, just a couple of days ago, had additionally accessed the presentation on our social media channels. Just on one upcoming event, we have December 14th at 3:30 p.m. Dr. Michael Golden will present Get Fit at Home, the right way, strengthen muscles while protecting your joints, and that will be on Facebook Live and YouTube. And those are my reports for today.
Thank you very much.
Thank you.
I think that's it. Is there anything else?
Nope.
Well, we don't have a need for a closed session this evening. So we are free to adjourn. I thank everybody for their comments and their participation and wish everybody well. We'll see you next time.
Hey, happy
Thank
holidays.
you.
Happy holidays.
Yeah.
everyone.
Happy holidays.
Oh, yeah. We'll see you.
Happy holidays.
All right.
Take care.
Very good. Good night.
Good night, everybody.
Good night, everyone. Thank you, everyone. Thank you.